To understand the collateral damage of an anterior cruciate ligament rupture, we have to look at the violent rotational trauma that causes it. When the knee undergoes a high-impact pivot shift, the ACL tears. The damage rarely stops at the ligament. Up to 42% of ACL-deficient knees harbor a simultaneous injury to the posteromedial meniscocapsular junction. Orthopedic surgeons call this a ramp lesion. The danger of a ramp lesion lies in how easily it evades detection. If a surgeon inspects the knee using a standard anterior arthroscopic view, the medial meniscus often appears completely intact. But shifting the camera to a posteromedial perspective reveals the reality. Hidden behind the condyle is a severe meniscocapsular separation. This physical concealment during arthroscopy is compounded by a diagnostic paradox on MRI. While standard imaging has an 88% specificity for these lesions, its sensitivity sits at just 70%. That means nearly a third of these tears are entirely missed by standard imaging. This creates a clinical blind spot that jeopardizes the entire joint reconstruction. The perimeniscal stabilizers are the knee's critical secondary defense mechanism. They restrict the movement of the posterior horn of the medial meniscus, limiting anterior tibial translation. When the posteromedial attachment is severed, the kinematics of the knee degrade. Without that tether, massive shear forces are transferred directly onto the ACL during flexion. If the surgeon reconstructs the ACL but leaves the ramp lesion unaddressed, those concentrated strain forces pull against the new graft, dramatically increasing the probability of graft failure. Protecting that graft requires moving beyond traditional criteria to identify the specific morphological markers of a hidden ramp lesion. In 1998, the definition of a ramp lesion was strictly confined to a tear at the extreme posterior attachment of the posterior horn of the medial meniscus. The modern diagnostic model requires an expanded view of the local anatomy, starting with two distinct perimeniscal anchors. First is the meniscocapsular attachment, which inserts superiorly to connect the capsule to the periphery of the meniscus. Second is the meniscotibial or coronary attachment, inserting inferiorly to tether the meniscus directly to the tibial plateau. The defining boundary for a modern ramp lesion extends inward from these attachments. It encompasses a strict zone reaching exactly 3 millimeters deep from the posterior periphery into the meniscal substance. If radiologists limit their diagnostic search only to complete capsular detachments, they will reliably miss tears localized within the attachments themselves or within that 3 millimeter peripheral zone. When looking for these lesions on MRI, identifying fluid-like signals separating the meniscus and capsule is the most specific finding we have, reaching up to 98% specificity. Yet it is the least sensitive, frequently dropping below 50%. The low sensitivity is a direct result of patient positioning. Standard clinical MRI knee coils require the patient's leg to be placed in full or near full locked extension. As the joint extends, the posteromedial architecture physically compresses. The space between the medial femoral condyle, the capsule, and the meniscus clamps shut. This compressive force prevents synovial joint fluid from pooling dependently within the meniscocapsular separation. Because the MRI scanner's physical constraints squeeze out the joint fluid, the most obvious radiographic sign of pathology is masked. Radiologists cannot rely on the presence of fluid. They must evaluate secondary morphological markers. When fluid separation is absent, the diagnostic target shifts from a gap to structural irregularity. This is a simulated T2-weighted sagittal view. Instead of looking for a fluid void, observe the contour deformity at the posterior periphery of the meniscus. This wavy, irregular edge is produced by torn and retracted attachment stumps. Next, interrogate that rigid 3 millimeter peripheral zone. Look for bright, vertical T2 signal that extends clearly to both the superior and inferior articular surfaces, indicating a complete longitudinal vertical tear. Alternatively, the signal may only breach one surface. These incomplete partial thickness tears often separate a distinct superior or inferior corner fragment from the rest of the meniscus. Finally, assess the surrounding bone. High-impact injuries often leave a secondary associative marker, subchondral bone neuroedema-like signal on the posteromedial tibial plateau. Peripheral contour deformity, particularly when paired with adjacent bone contusions, strongly predicts a ramp lesion. You do not need to see a fluid-filled void to make the call. Identifying these markers requires precision,
as the posteromedial knee is prone to false positives. The most common error is misidentifying physiological joint fluid in the perimeniscal recesses as a pathological tear. The differentiation rule is morphological. On the left, joint fluid pooling in a normal superior recess is smoothly marginated with intact perimeniscal attachments. On the right, a true meniscocapsular tear displays irregular, ragged margins and clearly discontinuous attachment lines. A second major pitfall is the misinterpretation of intermediate signal, regions where the T2 signal is brighter than the dark meniscal tissue, but not as bright as joint fluid. Intermediate signal does not automatically indicate an acute, unstable tear. Due to delays between the initial injury and the MRI, this signal often represents granulation tissue forming during spontaneous regional healing. Note the low signal strands physically bridging the gap. Not every meniscocapsular injury flagged on MRI requires a surgical fix. Recognizing the architectural signs of spontaneous healing prevents surgeons from undertaking unnecessary arthroscopic exploration for lesions that are already stabilizing themselves. Ultimately, MRI is a static tool. It maps the regional morphology with high precision, but it cannot definitively assess ongoing micromotion or functional lesion stability. True instability, the metric that dictates the need for surgical repair, only manifests under mechanical stress. It occurs when a probe forces the posterior horn to displace anteriorly into the medial hemijoint. If the probe reveals a stable tear, particularly one under 10 millimeters, the high local vascularity often allows the lesion to heal completely on its own without intervention. Therefore, the radiologist's core responsibility is not to plan the specific suture trajectory, but to precisely localize the injury within the posteromedial compartment. This localization compels the surgeon to look past the anterior view, utilizing an accessory portal or a pie crusting release to securely anchor the unstable tear. Advanced MRI interpretation doesn't replace the arthroscopic probe. It ensures the surgeon knows exactly where to push it, securing the meniscal stabilizers, protecting the ACL reconstruction, and preserving the longevity of the knee.